Okay guys, so next topic we have for today is aphakia. What is aphakia? Aphakia is absence of lens. You must be knowing it, है ना? Absence of lens. Now, what can be the causes of aphakia? Number one, सबसे पहला, which is surgical. Surgical means सर्जरी करी गई, लेंस को रिमूव कर लिया गया, सो सर्जिकल एफेकिया. सेकेंड इज ट्रॉमेटिक एफेकिया. ड्यू टू ट्रॉमा the lens got extruded out of the eye, so we'll call it as traumatic aphakia. Third is due to absorption of the lens, like in children. Due to trauma, what happened? There was a rupture of the lens capsule and spontaneously the lens material got absorbed. So that is absorption aphakia. Then we can also have congenital absence of the lens. So you'll call it as congenital aphakia. So these are few causes of aphakia. Right now, what happens in aphakia is due to absence of the lens, and we all know that lens imparts some power to the eye. What do you understand by Donder's reduced eye? So as per Donder's reduced eye, the power of the eye is plus 60 diopter, है ना? When the power of the eye is plus 60 diopter, in this very plus 60 diopter plus 43 diopter is contributed by cornea, while plus 17 diopter is contributed by lens. And when the lens is not there, what is going to happen? The patient will become hypermetropic, right? The patient will become hypermetropic. So this is the cornea, lens and retina. So normally what will happen? So the light rays will converge here. Now when this lens is not there, so it is not able to impart the 17 diopter component to the power of the eye. So ultimately the light rays are going to get converged behind. Am I understandable? Now having understood this concept, I am moving a step further. What will be the changes in the focal length of the eye? So as you all know, in normal eye, again I am making the diagram. What happens is the light rays are coming from here. So you know that there are two principal focal points. So one is forward, another is backward. So this is principal focal point for forward, this is backward. So I'll call it as F1, I'll call it as F2. Right now, since there is congenital absence of the lens, so I told you that the light rays will be focused behind the retina. So this distance, so I mean to say that the second focal point will be shifted behind the retina. So that means this is the shifting of the second focal point. So how much of the distance will there be this shift? So this will be approximately 7 millimeter. So now you can say that normal anterior-posterior length of the eyeball is 24 mm. So now the light ray will fall at a distance of 31 millimeter from cornea. Is it clear? So this is the shift in the second focal point. Now what about the first focal point? So how first focal point is formed? So when the light rays go, they strike the surface of the retina. The lights emerge from the surface of the retina. So lights are emerging. So similarly, in normal human beings, there is formation of the first focal point, right? Now similarly, as due to absence of the lens, the focal point, second focus got shifted behind. Similarly, the first focal point will be shifted फॉरवर्ड, हाउ मच, जितना पीछे गया था उतना ही आगे आ जाएगा. सो व्हाट इज द नॉर्मल f1? नॉर्मल f1 समवेयर लाइज एट अ डिस्टेंस ऑफ 15.7 mm from the cornea. So if we are going to add the same distance in the first focal point, it will become 15.7 plus 7 mm. It will become approximately 23 mm. Is it clear? So you will say that the first focal point will lies at a distance of 23 mm from the cornea. The second focal point lies at a distance of 31 mm from the cornea. So this you should understand. So that is the optics of aphakia, very very important, right? Now having done this, what will be the signs and symptoms? So you can say what will be the clinical features of aphakia. Number 1, sir, there will be jet black pupil. Absolutely correct. The pupil will be jet black in color. Is it clear? Second, there will be iridodonesis. So iridodonesis is when the pupil will constrict and dilate, there will be shaking tremors in the pupil. So that is known as iridodonesis. 3, the anterior chamber. What will happen to anterior chamber? Deep or shallow? Quick. It will be deep. So it will be deep anterior chamber. What will happen to the Purkinje images? You must be knowing there are 4 Purkinje images which are formed. So this is the cornea, this is the lens, this is the retina. So first Purkinje image is formed at the anterior surface of the cornea. Second Purkinje image is formed at the posterior surface of the cornea. Third Purkinje image is formed at the anterior surface of the lens. Fourth Purkinje image is formed at the posterior surface of the lens. When lens is not there, so what will happen to Purkinje images? There will be only 2 Purkinje images. Sir, which Purkinje images? The images which will be present in aphakia will be first and second Purkinje Sampson image. So there will be absent third and fourth Purkinje image. Absent third and fourth Purkinje image. Am I understandable? So these are few things that you should be knowing about aphakia. You can easily get a note on aphakia, right? Okay. So this is one thing. Another is you must have heard of something known as Cushion defect. Sir, what is Cushion defect? So for this you will have to understand. Cushion defect is due to one very important phenomena. What is that phenomena? That is spherical aberrations. Sir, सुना सुना लगता है ये spherical aberration, कभी सुना था, कभी कंसल्टेंट ने बोला था, बट ध्यान नहीं है. That is what I say, optics and refraction, anatomy and physiology is the most difficult part in ophthalmology. If you are able to do this, trust me, you will be able to know all the diseases automatically. Everything is linked. If you are able to understand these 2 topics in ophthalmology, optics, refraction, anatomy, physiology, let me tell you, the paper 3 and paper 4 becomes catwalk. Paper 2, 3, 4 becomes catwalk. This cakewalk for you, not catwalk, cakewalk for you. Okay. Spherical aberrations. So this is the normal cornea. So as you know, the more periphery will go, the more will be the curvature of the cornea, right? Now, if the light ray has to pass through the cornea, I am giving you just an example. So, if the light ray has to pass through the cornea, so I am just giving you a demonstration of spherical aberration. So, what is happening? So, there will be some bending of this ray, some bending of this ray. There will be some bending of this ray, some bending of this. The more periphery you will go, the more curve the corneal surface will become. So at the periphery, a position will come when the curvature is really more than that of the center. As a result, there will be more bending of the light rays. More bending of the light rays. Right? So this is spherical aberration. So how spherical aberration lead to pin cushion defect? So what you do, what happens in pin cushion, the more periphery the patient will go while wearing glasses. I am talking of a aphakic patient who is wearing glasses, right? The more peripheral the patient will go, the more bending of the objects will be seen. How? So if this is the object, let's say this is the object which is shown to the patient, right? So this is the normal object. So if the patient is wearing glasses, how it is going to look to the patient? It will be something like this. Do you understand? So centrally like this. So this is pin cushion defect and it is due to spherical aberrations. Spherical aberration, and this defect is seen when the patient is going to wear glasses. कौन से glasses डालेगा? Which glasses the patient is going to wear? Convex or concave? It is going to wear convex glasses. Now guys, please remember that the convex glasses which are given to the patient is of the order of plus 10 to plus 12 diopter, right? But the power of the lens is, I told you, approximately how much? Plus 17 diopter. Now you would say, sir, lens has been removed. The power of the lens is plus 17 diopter. Why we are prescribing the glasses of plus 10 to plus 12 diopter? Why not plus 17 diopter? Why? Because the more anterior you will place the glass, the less power will be required. Why? Because on placement of the glass anteriorly, you are shifting the focal length anteriorly. To give you an example, so if this is the lens, so this is plus 17 diopter. Now the lens has to focus image on the retina. So the distance between the retina and the lens is less. So it will require more power. Am I understandable? Now this lens is not there. Now you want to give the glasses. So glass is placed here. Now the distance between the glass and the retina is increased. As a result, you will require less power, because more is the power, less is the focal length. Less is the power, more is the focal length. So we need more focal length because the distance between the glass and the retina is more. So you require less power. So that is why we use less power, plus 10 to plus 12 diopter. Okay, so that was pin cushion defect. Now another phenomenon that I want to tell you here is jack in the box phenomenon. Jack in box phenomenon. So what is jack in the box phenomenon? There is a roving ring scotoma which is there. Now you know that when the convex lens is given, so every lens is made up of small prisms. Every lens acts as a prism. So it is like, it is the accumulation of multiple prisms that are arranged, right? So what happens is the lens is thick at the center and thin at the periphery. So you can convert this lens, just think about it, into two prisms. So it has become two prisms. Are you able to understand? So this convex lens, if you will see it, it will look like it is the form of two prisms which are attached with each other through its base. This is the base of the prism and this is apex. Apex of the prism, apex of the prism, and this is base of the prism, right? Now you know when the light ray pass through the prism, it will always bend towards its base. So light ray is coming like this, so it will bend towards its base. So light ray coming like this, it will bend towards its base. So that is why we get jack in the box phenomenon. How? So I'm going to explain you. So if this is the eye, so you have placed glasses like this. So what is going to happen? The light ray which is going to strike here. So here is the, let's say here is the fovea, right? So light ray which is going to strike here, now this will act as a prism. Now it will tend to go towards the base of the prism. So it will go like this. Am I understandable? Now since it has got diverted towards the base of the prism, it is going to strike at this part. It will not strike at this part. So as a result, the patient will not be able to see. So it is not striking the fovea, right? Similarly, what happens? There will be a scotoma which will be formed at this region. When the patient is going to see onto the right side, so what will happen? So let's suppose, so patient was seeing forward. Now the patient has turned sideways. So the patient has turned sideways, right? Now what happens? Now when the patient will try to adjust the eye, the patient will move here, his eyeball here and there. The moment this bending of the light ray will come in contact, the moment this image will start to fall onto the fovea, the most sensitive part, immediately the patient is going to see the object. So what was happening earlier? The patient was not able to see the object because the image was not being projected onto the fovea. But as the patient moved his eyeball a little bit, immediately the object appeared onto its fovea. And again, when the patient rotated his eye, again the object got disappeared. So it will be something like Jack in the Box. Jack in the Box is a toy. The moment you will open the box, there will be a puppet which will come above and then will go down. Come above and that will go down. Sudden appearance of the puppet. It is used to scare the friends. So that is Jack in the Box phenomenon. And the concept behind Jack in the Box phenomenon is prismatic effect. So pincushion defect is due to spherical aberration. Jack in the Box phenomenon is due to prismatic effect. Now another point I want to tell you here is that I am talking of the glasses which are prescribed. So glasses में what we do is, there is, for every 1 diopter of the power that we give, there is magnification of 2%. Similarly, if we are talking of concave glasses, for every 1 diopter there is minification of 2%. There is minification of 2%. So I told you what will be the power of the glasses that we are going to give. The power that we are going to give will be 10 to 12 diopter. Let's take it plus 12 diopter for the timing. So the amount of magnification that there will be of the order of 25%. And guys, let me tell you that if the difference of the size perceived by two eyes is more than equal to 5%, there will not be stereopsis, binocularity. So it will become difficult for the eye to have binocularity if the size of the object perceived by two eyes, if the difference is more than equal to 5%. So that is one very important point. So as you know that there is disparity of the order of 25%. That means I am going, if my right eye is aphakic and I am wearing aphakic glasses in my right eye. So boys and girls, from the right eye, a object is seen magnified of the order of 25%. So there will be magnification of the order of 25%, right? Okay, and you must be knowing that sometimes the doctor may ask the patient to wear contact lenses because some people may find the spectacles not cosmetically गुड है ना. सो इसलिए सम डॉक्टर्स में आस्क द पेशेंट टू गो फॉर contact lenses. Now I am going to give you a one very important formula. Now if you want to wear the contact lenses of the same power, let's suppose plus 10 diopter, so how much power would you use in the form of contact lenses? So contact lens, first we'll have to see the contact lens magnification. So contact lens magnification is 1 minus d into fs. What do you understand by that? D is the distance of contact lens from the cornea. So normally it is 14 millimeter. So distance of contact lens from the cornea is 14 mm. So contact lens magnification is 1 minus 14 mm into power of the spherical glasses. So here mm it is taken into meters. So 14 mm will become 0.014 meters, right? So contact lens magnification will be 1 minus 1 minus 0.14 है ना, 1 minus 0.14, it will become 0.86. So this is contact lens magnification. So that means in relation to the glasses, if there is a hypermetrope, so there will be less of the magnification, which will be approximately 0.86 times. But if we are talking of myopes, if there is minus 10 diopter of the myopic and we want to prescribe him contact lenses, so another contact lens magnification will be 1 minus 0.014 into minus 10, so it will become 1.14 because minus will become plus. Please remember that if we are giving concave lenses, right, the magnification will become more. So myopics, the magnification will be more. I am talking of more with respect to the glasses, not overall more. Overall more in concave lenses, there it will be minified, but in convex lenses it will be magnified. But if we consider difference between the glasses and the contact lens, so here it will be relatively less in hypermetropes and it will be more in myopes. Am I understandable? Now how will you assess which power of contact lens is to be prescribed to the patient if you have got the spherical power of the glasses? So there's a formula in regards to that, and that formula is so the power of the contact lens which is to be prescribed, and we know the power of the glasses, so it will be 1 minus dfs. So what I mean to say here is, if the person is wearing, let's suppose, plus 10 diopter glasses, now you want to prescribe him the contact lenses, how much power are you going to give to the patient who is wearing plus 10 diopter glasses? So it will be plus 10, that is the power of spherical glass, 1 minus 0.014 into plus 10, so it will be plus 10 upon 1 minus 0.14, right? And it will become 10 divided by 0.86. So whatever value that we are going to get, we are going to give it in the form of the power of the contact lens. Am I understandable? So it will be more for hypermetropes, and similarly it will be less and less for myopes. That is why we say कि अगर किसी को -3 की पावर लगी हुई है और वो कॉन्टेक्ट लेंस पहनना चाहता है तो 0.25 वो कम भी डाल सकता है. इट्स एब्सोल्युटली ओके. बिकॉज हाउ? बिकॉज ऑन एप्लीकेशन ऑफ दिस फॉर्मूला देयर विल बी सम डिस्टेंस, एंड दिस इज नोन एज वर्टेक्स करेक्शन. हमने वर्टेक्स करेक्शन कर ली. ग्लासेस कहाँ पे आएंगे और कॉन्टेक्ट लेंस पीछे आएंगे उसके, है ना. कॉन्टेक्ट लेंस इज इन टच विद द कॉर्निया, व्हाइल ग्लासेस they lie a little far apart from the vertex of the cornea, from the center point of the cornea, है ना. So that is why we have to do this correction. Okay, this was some extra point that I wanted all you guys to know. Now getting back again to aphakia. So we have done what clinical features we are going to see in aphakia. Now what will be the treatment of aphakia? So treatment, I have already told you. Number 1, glasses. Number 2, keratophakia. Sir, what is keratophakia? Kerat word is used for cornea, phakia is used for lens. So what do we do in keratophakia? We actually take patient's cornea, and what we did, we actually remove the superficial surface of the patient's cornea, and in between two surfaces of the patient's cornea we actually implanted the graft cornea. So what we did, we implanted the graft cornea in between the two layers of the patient's cornea. So eventually we have increased the refractive power of the cornea, so that will compensate for the loss of refractive power of the eye due to aphakia. Am I understandable? So that is known as keratophakia. So one is you actually take a flap of the cornea, you place the graft cornea and you close the flap and then suture it. So that is one thing. Third is what you can do. Here it is keratophakia, then we have got epiphakia or epikeratophakia. Epiphakia or epikeratophakia. So epi means above. So what we did not actually create a flap. We simply sutured the graft cornea over the surface of the patient's cornea. So if this is the cornea of the patient, we simply sutured the graft cornea. So epi माने ऊपर, above. So this is epikeratophakia. So next we have is Lasik. Lasik, hyperopic Lasik. Hyperopic Lasik. So guys, please remember we have done it in one of the videos on Lasik surgery. So in Lasik we can correct the myopia up to -12 to -14 diopter. Some books write -10 to -12 diopter. We correct hypermetropia up to +6 diopter, and we can correct astigmatism up to +-3 diopter by Lasik, right? So this is a excimer laser.